from wherever you are connecting from, and thank you very much for joining us for this edition of the South to South Learning Network Link and Learn session on young key populations. We are particularly very excited to be hosting this session in collaboration with our colleagues from Kenya, exploring experiences and best practices on programming for young key populations in these two countries. And we're particularly keen to see if we can have a very robust conversation that can facilitate some linking and learning amongst our South to South network countries. As you may be aware, this is the first session on our link and learning that is focusing on young key populations, but it's really not a first with the South to South Learning Network. We have had a similar session that we have held with the Global Prevention Coalition, where we particularly spoke to programming for young key populations sometime in June. So just as a way of introduction, we all appreciate that HIV incidence amongst young people is very high, particularly in specific locations in Eastern and Southern Africa, and that young people who include young women of cell sex, young gay and bisexual men, and other men who have sex with men, young transgender persons in their diversity, young people who inject drugs, and young people in prison and closed settings are particularly at high risk of HIV infection globally, and they experience policy and structural barriers that make access to HIV really a big challenge. So like I said, the Global Prevention Coalition and the South to South Learning Network did convene a virtual webinar in June 22 to explore this topic of scaling up effective programs for young key populations. And we are taking the lead from that conversation to do a deeper dive for within country, and particularly glean lessons where colleagues should feel free to ask questions and really interrogate some of the best practices coming out of these countries. We really particularly spoke again to some of the principles for programming with young key populations that included doing no harm approaches and using or utilizing human rights-based approaches, and being gender transformative conscious, being gender sensitive in our programming, using evidence to lead programmatic interventions, ensuring that we particularly respect choice and that our interventions are user-friendly, and that we meaningfully engage and involve young key populations in participatory approaches towards programs that work to reach out to them, and that we do affirm sexuality in the responses that we do. We also know that in the recent past, during the International AIDS Conference that was just held in Montreal, Canada, there was a dissemination of the latest WHO guidelines for key populations. So these are the combined guidelines for the management of HIV, STIs, and hepatitis amongst key populations. And I'm going to ask Pari if we do have a link. Please kindly do share the link to the guidelines on the chat box for colleagues to easily access and engage with these as we continue to nuance our programming for young KPs. There is a very rich chapter that I had an opportunity to go through in these past 3 days that particularly guides how we engage or how we develop and improve programs with and for young key populations. And also during the earlier presentation that we had, or the earlier Global Prevention Coalition webinar that we had, young people really did stress a few things that they needed to be included. We need to include young key populations in the design and in the implementation of their programs, and also to increase funding to key population-led organizations for program implementation, and that we also improve multi-sectoral partnerships to address the varied needs of young persons, and that will also fulfill the human rights obligations by repealing the discriminatory laws and policies that criminalize key populations, from criminalizing same-sex sexual conduct, criminalizing the sale of sex work, criminalizing injection drug use and possession, etc. So they also spoke to having young people represented in positions of leadership and the use of technology to facilitate different models of learning to improve their skills. So these are preliminary discussions that we have had, and we are going to have a lot more of these. We have a program that we have flighted already. Right now, I was just sharing the opening remarks to set the tone for these conversations. Briefly or shortly, I will be calling on Janet Musimbi-Mbole from NASCOP Kenya to particularly give us their perspectives or experiences programming with young key populations. We're going to get into a panel discussion that is going to be facilitated by Parinita. And we're also going to hear from the Almasi challenge, and we will have a panel discussion, and then we'll have another presentation from Zimbabwe on their young female sex work program. And before we close, we'll have a question and answer and take time to get into the questions that you have momentarily. Without much further ado, I think we'll get directly into the program, and I'll take this opportunity to invite Janet Musimbi-Mbole to share a presentation on the work that they're doing in Kenya. Janet, if you're ready, over to you. And kindly, may I still ask colleagues who have not introduced themselves to continue on the chat box, sharing who is here. Janet, over to you.
Thank you so much, Humphrey. I hope I can be heard.
Yes, we can hear you. Take it away.
You. So on behalf of the program, the KP program in Kenya, I'll just do a brief presentation on the young KP program that we have. And just to give a background of HIV Kenya and the key populations in the country, we know that Kenya has a mixed HIV epidemic, where we have the concentrated and the generalized among the general population, concentrated among the key populations. And when we look at our key populations in the country, they include the female sex workers, the men who have sex with men, the transgender people, and the people who inject drugs. And looking at their contribution to the HIV, new HIV infections in the country, they contribute 33% of all new HIV infections. And due to this and the fact that they also the high HIV prevalence that they have, we also have had size estimations exercises that have been done. We have high estimations of the key populations, looking at around 197,000 for the female sex workers, 51,000 for the MSMs, 35,000 for PWAD, and around 4,307 for the transgender persons. This has all contributed to the fact that we need to program for them, including the fact that sex work, drug use, and same-sex relationships are criminalized in the country. Next, please. So why focus on the young key populations? As a country, one thing that happened is that it was recognized that adolescents and young people, especially between 15 to 24 years, contribute to 42% of all new adult HIV infections in the country. And one of the key things that we looked at and what the country did, we developed a Kenya fast track plan to end HIV and AIDS among the adolescents and young people. This was in 2015. And this document, together with the fact that it was recognized that adolescents and young women who engage in sex, that is either casual, transactional, or sex work, through a study that was done known as the transition study in 2015, showcased that they were limited in access to prevention services, especially when the others were getting services in the hotspots. And it was recognized, and through several studies that have been done, that young key populations' risk and vulnerability were higher than for the other key populations. And this was based on a polling booth survey, where it was an outcomes assessment that was done in 2017. And then the other key thing that happened for the country was that it was noted that 10 to 12% of the key populations in the are found in the KP locations were below 18 years. And one of the key things that this was done when the size estimate that we did in 2019, 2018 recognized that young key populations are actually found within our hotspots, but then we did not have guidance on how best were we able to reach them at the same time, because looking at first the nature of the activities they're engaging in, and also looking at the fact that they were below, some of them were below 18 years of age, how then best were we going to be able to reach them, out to them with services. So best, you can see that as a country, one of the key things that we had to generate evidence to showcase that why then do we need to focus on young key populations, and things like the transition study, the Kenya Fast Track Plan was able to just support this evidence that we had. Next. So based on all this, quite a number of engagements sessions were held. We had to have discussions with different stakeholders, bringing in all the players who work with young people in the country. And after further and several discussions, you can see all this started, if you've seen what I've shared, we started all the way in 2015 looking at study, collecting data and evidence. And in 2018, we were able then to have the National Key Population Program develop the national implementation for HIV and STI programming among the young key populations in the country. And this then was able to provide a comprehensive package of intervention based on the global and national guidelines that we had on how best then as a country and how the different programs that we work with would be able then to reach out to the young key population and ensure that they were able to access services. This guideline adopted of a combination prevention approach, and it's basically based on evidence and intensive consultations with young key populations, so that then we needed to make sure that their voices were heard and that we were able to factor in and ensure that what services they required or felt that were important to them were then included in the guidelines. Next, please. So to further just look at how best then would these guidelines be able to be used, and just to ensure that the guidelines really met the needs of the young key populations before scale up, we were able then to do a pilot project. And NASCOP was then able to pilot interventions with young men and women who sell sex, as well as young men and who have sex with men. And they basically, based on the different data that we were able to look at, for example, we were able to look at some of the data was looking at registration of the young key population, that is the young women who sell sex, as well as the young men MSMs, in terms of just looking at registration into the program to showcase that they were willing to be part of the program, just to look at some of the services that they were taking up, and looking at, especially for those who are maybe on treatment, how are they accessing that treatment, and just looking at other different interventions that were able to happen. And basically looking at the data and on what had happened, and through having this intervention through support of partners that was looking at MAAYGO, we had MPEG and also ICRH, which were our pilot sites. It was realized that then having interventions for young key populations in the country was feasible and effective. And based on this data, then it was felt that then as a country, then we needed to prioritize the young key populations in our program and have the scale up of the project in the country. Next, please. So currently as a country, we're looking at then the scale up of this. And as I've already discussed some of these things, one, we needed to ensure that there was consolidation and documentation of the evidence from all the research that was done, that was targeting the young key populations. We had assessments taking place, and then looking at also the pilot programs that took place, and looking at evidence from those pilot programs. And as I've earlier indicated, that it was based on the evidence from them that it was noted that this was a program that was feasible to happen. We had to ensure that there was advocacy with community networks, county governments, stakeholders, implementers, and basically the technical working group. Because remember that, for example, in the country, looking at like our programs, which are health-based, health is devolved, you needed to ensure that the county governments understood what it meant to have programs for the Yankee population. We had to bring in different stakeholders on board to ensure that they understand the program, they're able to understand why are we targeting Yankee populations in the program, and what their needs were, and how different was this program from the mainstream the mainstream key population program, and what are the different things that need to be brought on board. And then the other key thing that we needed to ensure as we scale up the program was that there was monitoring of the program, and that we were disaggregating this evidence and different services being provided by age. So for example, if you go to our KHIS, we are able to identify the different services and the different age groups for the Yankee population in terms of how they're accessing services and the uptake of services for them. And then the other key thing that we have done as a country is just to ensure that we have included in the Global Fund proposals, scale up for the different geographies and also for the young subpopulation. So that then in that we are saying that we have tried to ensure that in the Global Fund that we are putting in place places for scaling up and ensuring that different partners who are being given targets and being provided for funding to be able to reach out specifically to the Yankee populations in the different geographies they were working in. Next, please. So basically, one of the key things that we also have done as a country, and basically just to document our journey and what we've been doing with the Yankee population, we have been able to, just so that then we're able to showcase this and share this with other partners and other countries, we have managed to come up with a virtual tour of film that documents what our pilot projects did that involved the young women who sell sex as well as the young men who have sex with men, and that the learnings are now being replicated in other geographies to be able to scale up and cover all Yankee populations. And I believe next we'll just be able to have a look at that film, just to be able to understand how we went about having the program and how best can we use that to be able to scale up and replicate in other areas. I think next will be the film. Thank you.
Kenya is a country of great diversity. Straddling the equator, it is home to the Big Five and cultivates some of the world's richest coffee and tea strands. With a savanna within its borders and the Indian Ocean off the coast of Mombasa, the Kenyan landscape is a cataclysm of contrasting beauty. Home to 50 million people, it is against this backdrop that one of the largest HIV epidemics in the world exists. According to data from the National AIDS Control Council, 42% of new HIV infections occur among adolescents and young people. Part of these are young key populations, and they represent the proportion that is at a higher risk of contracting HIV and include young men who have sex with men, young women who sell sex, young people who inject drugs, young transgender people, and young people in prisons. Even as young key population are recognized as a vulnerable group, the global response to HIV has largely sidelined young people. To address this, Kenya has developed the Fast Track Plan and the National Implementation Guidelines for HIV and STI programming among young key population. A pilot intervention was initiated with young men who have sex with men and young women who sell sex in Kiambu and Mombasa respectively. We partnered with MPEG, a KP-led organization in Kiambu, and ICRH Kenya, an NGO which works in Mombasa.
Kwa majina naitwa Margaret Wamboka, nimetoka mtaa Bombolulu. Napenda sherehe, napenda sheshe, kutoka nje na mabeshte, kuchonga, kukunywa. Yaani hivyo ndio mimi tu anapenda. Kuna siku ilikuwa naenda tu kibarua tu hivi kama kawaida, nikakutana na Pia. Sasa huyo Pia akanielezea, akaniita, mambo poa dada, kuna services tunafanya pale DIC kama unataka family planning. Alafu nikikumbuka ndio nimetoka kuzaa, alafu sijui mambo na family planning. Akanielezea kuna miezi 3, kuna miaka 5, kuna zile pills. Alivyonielezea, alafu akaniambia kuna tembe zinaitwa PrEP. Alivyoniambia hivyo, nikafikiria, nikamfuata paka huko DIC. Nilipofika nikapatiwa service, nikaelezea, nikapatiwa counsel.
Young key populations not only experience higher risk of acquiring HIV, but are also vulnerable due to a myriad of social and structural factors. For example, while unprotected sex is a significant risk factor, there is evidence that young key population are often more vulnerable to effects of poverty, discrimination, harassment, violence, social isolation, criminalization, and self-stigmatization. In addition to addressing multiple overlapping risks, programs with young key population are working towards developing supportive policies, providing stigma-free services, improving access to scholarship for education and skills training, violence-related support, among many others.
Nilivyomaliza hizo service, sasa nikakuja na mimi pia nikaelezea wenzangu. Pia wenzangu nikiwapeleka wanatumia hizo PrEP, hizo service za family planning. Sasa pia huko kwa hotspots, kwa sababu pia mimi nabangaiza. Sasa zile service zilinisaidia DC, nikaambia na wenzangu sex worker wadogo, nikawaelezea kuhusu hizo service, na wapeleka pia nao wanaambia wengine wanaenda.
There are a host of reasons why young people, particularly adolescents and young girls, sell sex. Poverty, gender inequality, and limited access to education are just the tip of the iceberg. Yet even while Transitions research from Mombasa indicates that 52% of women who sell sex in sex work locations are below 24 years, they remain underrepresented in research and HIV prevention programs.
I came to know MPEG at around 2017 after high school. You know, this was the time when I was so naive. I didn't know things about how I can prevent myself from HIV or from STIs, or where I can get services. So I came across a friend who was actually working in this DIC, and he introduced me here. At first I was hesitant because I thought maybe, I don't know these people, what are they going to do to me? But after some time, when I got here, the reception was very welcoming. So I registered my name, went to the doctor, had a conversation with the doctor, and I got enrolled.
So there was need to bring those hard to reach people, youngsters that are online, are all over online, and they don't want to come to sex services. Youngsters want to be reached by youngsters. I want mtu tunaongea na yeye ana resonate na mimi, tuko almost the same age. Alafu si kukwambia tu, don't just tell me about coming for HIV. You see, that is what have led a lot of sites not even have young people, because our sites have become like hospitals. There is nowhere you'll find youngsters chilling together, playing PS, watching a movie together, doing makeup. You see, having a movie night, kukula popcorns pamoja. There is no that, because our sites have become hospitals. Unasikia tu madawa, unasikia tu watu wagonjwa. So there was that gap to change, to make it more friendly, to attract more people, more youth to come to the center. And you will find them. You will not find them in the streets. You'll find them on social media. We have social sites, we have groups, and all those social network and sexual networks. Those are two places that you'll find a lot of youth.
The way they welcomed me to the doctor, I was already comfortable with their services, and once I got to the doctor, he introduced me to the organization. He told me what they do. They offer HIV prevention services, they give STI services. In case you have any diseases, you can come here and get any service for free. This was something that was really exciting, because I was used to going to like public hospitals, and when you go usually to public hospitals, most of the time they won't make you feel home. So the kind of reception that was here made me feel good, and I think we had a connection, and I came and started receiving services from the DICE.
Data on young men who have sex with men is scarce. However, emerging numbers point to them having heightened risk and vulnerability. There are a few programs specifically tailored to their needs, which limit their access to sexual health education and services. They also face criminalization and the stigma attached to same-sex relationships. As a group, they are at increased risk of abandonment and violence from their families.
We normally offer services to the young KP, that is the biomedical intervention, structural and behavioral. We also do the psychological support to them because most of them are actually going a lot of mental health challenges. And most of them, they find these places a bit safe for them to come and share with us. So we do offer the services to them still.
The country has developed guidelines to inform national programming for HIV and STIs among Yankee populations. The guidelines emphasize the need to involve the Yankee population at all levels of program and policy design, implementation, and evaluation so they can own the program.
Yeah. Mimi hadi nikiwa tawa, I can just peep in, kukaa kiasi, relax, wifi deals ni kwa manda. Hiyo pia inasaidia uko na place penye hautaenda ukae ulizwe ni nini unakuja kufanya.
Yeah. Una feel at home, you can do anything you want. Like no one is there, no one is judging you. Unakuja kani lunch time maybe you're working na kama una chill. Kama leo. Venye tulikam unapata kuna wase wengine hapo at least unaweza ongeleshea. Sisi tutakam unapata mabest, you can make friends.
Watu wa form wanakuja kupikia form. It's just fun hanging out with friends and for your well-being.
Children and adolescents below the age of 18 are exceedingly vulnerable to sexual exploitation. They have a greater inability to negotiate safe sex, access sexual and reproductive health services, and exist under the constant fear of harassment and exploitation. This drives them away from programs and services, making them invisible. Yet young KPs are protected under several laws, including the United Nations Convention on the Rights of the Child, UNCRC, the African Charter of the Rights of the Child, ACRWC, the Constitution of Kenya, and the Children's Act of 2001. These provide for the survival, development, protection, and participation rights of YKPs.
The challenges we face in programming for young KP are many, and some of the issues we find is during our outreaches and being in places where sex work is happening, we find young girls and boys under 18 who are selling sex. Since they're already in those areas, we provide services for them. And so we'll give them services like sexually transmitted infection screening for them, HIV testing for them, provide treatment. But before that, the most important is linking them to child services.
Yankee population need to be effectively included in the HIV response. To do this, an understanding and recognition of the emerging needs of this group is required.
The policy guidelines have in various ways contributed to addressing the needs of YKP. The first thing is that the policy guidelines give practitioners and programs some level of confidence to approach KP or YKP service delivery. So one of the things you find or you know is that it's quite controversial providing sexual reproductive health services to young people, and many clinicians are often reluctant to provide sexual reproductive health services to young people. But one of the things the guidelines have done is that they now health service providers and programs are aware that there are policies and that there are guidelines and that they are operating within a legal framework, and that gives them a lot more confidence to provide services to most or to many of these people.
For the government of Kenya and the counties, it has been that challenge of ensuring we meet the prevention need as we work towards abiding by law and working towards behavior change. And so to facilitate this, we set up county key populations TWGs, whose role, apart from the general key population, has been to address emerging concerns and trends around key population program and prevention needs. And so this has become a concern in all KPTWGs, and that has given a platform for engagement with the stakeholders who have a responsibility over young people who are KP in their lifestyles, bringing together education, security, judiciary, and that has given the structural environment for provision of prevention services.
While programming for young key populations is still in the early stages, it is essential to anchor the provision of services to select key principles. These include ensuring that young key populations have their voices heard, minimizing harm to them, not discriminating on any grounds, and remaining aware of their vulnerability. To achieve maximum benefit, collaboration with families, community leaders, county bodies, and different sectors will be essential. Young key populations have needs beyond HIV and health, and hence the program would have to ensure that all these needs are met in partnership with other organizations.
There was really a gap to really reach out to the young KP because they have needs that cannot be reached in the mature program, because these are young people, and for young people they need a lot of sexual and reproductive health services. They need a lot of integration of youth services and youth-friendly services. For the general KP, it's just ensuring that, of course, you reach them with specific services, but services that are KP-friendly. But for this one, apart from KP-friendly, it also has to be youth-friendly.
We need to create an environment whereby young key populations can actually share. That is ensuring that there is safe spaces, be it at drop-in centers, be it just, at homes, because young key populations are part and parcel of the community. And since they are our leaders of tomorrow, we need to ensure that they are equipped with education. And this only happens at safer spaces.
Sasa mimi nina miaka 22 na niliingia DSC nikiwa na miaka 17. Nashukuru imenisaidia kwa sababu ilikuwa sijui mambo na family planning, wakanisaidia. Hasa nashukuru DSC kwa kunielimisha.
The lessons drawn from programming for young men who have sex with men and the young women who sell sex are being utilized to scale up programs for all young key populations in Kenya. If you'd like to learn more about Kenya's programming for young key population, send an email to NASCOP through their website www.nascop.or.ke. Are you a country champion and want to create a virtual tour of your own program? Please reach out to SSLN Virtual Tour Champions, Winfred Nduku and Thomas Offem.
Thank you so much. This was a wonderful film. Every time I see it, I learn a little bit more about the Kenya program with young key populations. At this point, I would invite Dr. Griffins from ICRH, Samuel Kuria from MPEG, and Mary Mugambi from NASCOP for a short discussion. It would be great if you could switch on your camera so people can see you. Obviously people have seen you in the film. You were, 3 of you were speaking in the film, but would be good for this discussion too. I would also request those who are listening to this presentations and discussion today to write your questions in the chat box. And in case, if we have time, we will do it during the panel discussion. But if we do not have time, then I'm sure Dr. Griffin, Samuel, and Mary would be happy to respond to you in the chat box. My first question is to Dr. Griffins. Dr. Griffins, we saw such a wonderful program that you are running for young key populations, young females, young women who sell sex. But if you have to do it again, how would you do it differently? What's your advice for other programs who are trying to work with young women who sell sex?
Thank you very much, Parinita, and good afternoon, good morning, everyone else. I hope you can hear me well. I hope I'm audible enough. Perfect.
Yes.
So thanks very much. And yeah, so it was, so the Young Female Sex Work Program was very interesting. We at the International Center for Reproductive Health implemented the female sex worker component of it. It was a very unique and a very new program, and one of the things that of course it was challenging, but at the same time there was quite a lot that was to be learned from it. So to go directly to your question, of course there are a couple of things that come to mind in response to your question. But the first thing I think we could have done differently is to allocate a bit more resources towards other non-clinical parts of the program. We could have allocated a lot more resources towards cohort building for young female sex workers, towards having the young women who sell sex rather, participate more in programs that are aimed at creating a culture, creating an identity. So one of the things we noted was that a lot of the activities, or during many of the activities we had that were non-clinical oriented, so many of the times we had activities to what we call thematic days. So sometimes we decided that, for example, this Friday, we would have free makeup for the young girls, or we would have activities that just encourage the young girls to come together and share experiences. The uptake and the participation was quite well done. Unfortunately, at the point of designing the study, we hadn't put in a lot of resources on that. I mean, we had put adequate resources, but learning from the implementation is that we could have done a lot more with a lot more resources allocated towards activities that encouraged uptake of, or at least encouraged participation of the young women in program-related activities. I don't know whether that makes sense.
Thank you. Thanks. It does make sense, Dr. Griffins.
Thanks for it.
And please have a look at, keep looking at the chat. If there are any questions, please make sure that you get a chance to respond to those questions. I'll move to Samuel Kuria. Kuria, you run MSM-led organizations, MPEG. You are doing interventions in several counties, and maybe you're going to be expanding to other counties. So if you have to expand your young MSM program to other counties, or even other countries, what lessons that you have learned from this implementation that you'll take to those counties? Kuria?
Yeah, thank you so much, Parinita. And this was just an eye-opener, and having a pilot site in Kiambu, which is actually a peri-urban kind of setting, it really made us also rethink of strategies of how to be able to reach out to the young generation. Looking even at our geographical coverage, where we have a lot of also institutions, we have learned a lot that most of the people who are coming to our sites, most of them were not actually reached through the hotspots, but actually most of them were reached through the digital platforms. And we were able to look at it innovatively, how best, and the reasons why they were not actually coming from the hotspots, but they were getting this information from digital platforms. And we learned that to reach the young people, or to be able to reach to these young adolescents, you have to send people or have peer educators who are young like them, because they resonate well with them. And also we've learned that making our safe space, not just a safe space, but a friendly one and a youthful kind of space. What kind of activities do the young people want to see? They don't just want to come and get tested and run away from home. They want to come use Wi-Fi. So you provide that. Those are some of the lessons that we have gotten, that if they want to come, there is a game, for example, if there is a PS or EFL is playing, there is a Manchester versus Chelsea. We are able actually even to put that on the safe space so that they watch, they enjoy. And this also makes sure that they are able to tell their friends that there is this space that we have, there is this place that we go to, and there are these kind of services. They are not just clinical, they are not just biomedical, but there are other interventions that the young people or the adolescents would really resonate with and attract other people. And we've learned also through Quick Race, which was a step one from NASCOP, which was actually a project that a lot of our population want to book their own, even their own appointment with a clinician. They don't want to come when the DIC is full of other older people. They want to come on a Saturday. They want to come on a Sunday. They want to come with your friends. Probably they were having a party somewhere. They could actually book and come to a specific time of the day. Like for example, at 6 p.m. Are we able to offer that opportunity to be able to see the young people? Something also we have learned is that the good environment that have been set by our counties and the national government coming up with guidelines that they might not be fully the best, but they are enabling us or enabling programming in Kenya to be able to be safer for the young key population. I think those are the lessons that we have learned. Thank you.
Thank you so much, Kuria. Kuria, I see there is a question for you. We may not get a chance to speak about it, but I would request you to respond to it in the chat box while I go to Mary Mugambi, who represents NASCOP. Mary, I see that you have developed guidelines, you have created an environment in Kenya, which has been helpful in scaling up programs with young key populations. So if you have to advise another national government who is trying to scale up programs for young key populations, what would be your advice, Mary? Are you there, Mary?
Yes, yes. Thank you, Parinita, and confirm you can hear me, please, and see me.
Yes. Yeah, both.
Thank you. So I think the journey to begin a young KP program is basically based on the experience that you had running KP programs over time for the key populations programs, obviously those who are 18 and above years. And the fact that we already have structures and we already have a national system, we have a program which has a monitoring system, we have a national coordination system, we have the technical working group. Having that helps, because you can't just start a young KP without having an existing KP program. That is one. The other things that you require is addressing the policy issue. And for us, working on a guidance document was the best thing we could do, because health workers don't want to go against the law when they're giving services. And as we were going through the video, we saw that how do you give services to somebody who's underage? So some of the things we've done is sensitization. And it's important to sensitize all the key stakeholders. It's important, once you have a guidance document in place, you disseminate that at the various levels. You have it done nationally, you have it done within counties, you have it done within facilities and the healthcare workers. Other things, including stigma and discrimination, and having health workers who are offering key population sensitive services is also very important. The other issue that needs to be addressed is resource mobilization. It's always important to look for resources for this population, and using advantages of any donor funding that you have. It's also important to look at resources that are domestic, so that you have sustainability, but also getting into the process for global fund. As you're writing, can you have a focus specifically on young KPs? What are you going to do based on the evidence that you have in country? And working through the COP process, for us, we have the and we have worked to ensure that is also worked on. And then to develop and track prevention treatment cascade. for young guide programming. For the 1990 that they are virally suppressed, those who are positive were put on treatment, and ensuring that you link them to services. One of the things we have done is having introducing the children's department so that they engage in our technical working group, so that they can be able to offer services for these children, because there are some who want to leave key populations work. There are some who are still there and doing it. How can they get the assistance that they can using the children's department? Thank you, Parinita.
Thank you so much, Mary. I know we are short of time, so we'll have to move to the next presentation, but I wanted to sound it out to Dr. Griffins. You have a question in the chat, and it comes from Helga, who has been part of this program and knows your challenges. So I think she wants you to focus a little bit on other stakeholders that you engaged with. And then there is another quick question from Grace from Malawi. And she is also asking about the specific package of services. And Janet and Mary, you may be able to share that in the chat, because I know Kenya has a guideline which is specific package of services. As we are talking about digital platforms, mobile platforms, I'm going to invite the team from Almasi who did the Almasi challenge, Theo, Ken, and Pascal, to do your next presentation. Thank you, panelists. It was wonderful chatting with all three of you, Dr. Griffins, Kuria, Mary.
Great, thank you so much, Parinita. Let me just switch so that I can share my screen. Sorry, do this. All right. Great. So, hello everyone. Welcome. Can everyone see the screen and the slides? Okay.
Yes, please.
Okay. Perfect. Excellent. Well, we're so glad to be here. Let me just, great, there we go. We're so glad you're here. My name is Theo Gibbs. I am joined by my colleagues Pascal from HOYMAS, Kennedy from MAAYGO, and thank you so much to Parinita for inviting us to present our work on the Almasi program today. And you've been an advisor to this project from the start, so grateful for your guidance throughout. So we're going to go through some results from our pilot that was completed last year. Building on the discussion so far. So I won't stay on this too much because we've already had a great framing of the challenge in terms of why it's important to focus on HIV prevention and care for young MSN in Kenya. And so that was what this project was focused on, young MSN ages 15 to 24. And specifically, I want to highlight that even though there is this there's such a mandate to focus on young MSN, there's still not very much of the global funds go towards the HIV response towards young MSN. So this was a project we were grateful to have the funding from ViV Healthcare, which put forward the funding for this pilot and the supporting work to tackle this important issue and bring innovation into this space. So to frame, the Almasi pilot was an intervention that emerged from a young MSN focused innovation challenge. And this pilot was implemented last year. And so the quick takeaway results to hopefully get your attention were that we saw an over 800% increase in HIV testing among young MSN ages 15 to 24 who had never tested, and over 100% increase in those who had tested longer than 6 months ago. We also were glad to see that 93% of those who tested positive were successfully linked to care. And so those are the quick summary takeaways. And now that you know those high level results, and hopefully are curious about them, we're going to walk you through what the intervention is that we piloted, how it works, and then I'll pass to Pascal and Kennedy to speak about the pilot results and lessons and learnings in more depth. So going through what the intervention is. So the overview of the pilot was These were the partners on the project. For MAAYGO and HOYMAS are both KP-led community-based organizations, MAAYGO in Kisumu and HOYMAS in Nairobi. And so both organizations have a long-standing HIV outreach and service delivery program and relationships with local and national government stakeholders. I'm representing YLabs, and our role in this project was to provide intensive training to MAAYGO and HOYMAS on human-centered design and on developing youth-driven interventions, in this case, KP-driven interventions. And we also provided the visual design and led the evaluation of the pilot. So the pilot was implemented over 4 months in 2 countries, in 2 counties. So the goals of the pilot were these. So we were looking at how do we increase access to HIV prevention and care for young MSN in this age group, and then specifically wanted to focus on how to reach new young MSN who were not currently engaged in MAAYGO and HOYMAS's programming. So new, especially new and infrequent testers, which, as many of you know, is a particularly difficult demographic to engage because of the stigma that was presented in the video and framed, I think, very well. But of course, very important to reach this population in order to reduce transmission. So the Almasi program had 3 core parts. First was a targeted ad campaign, digital and physical media, to reduce stigma and encourage testing. And this was these ads and encouragement was distributed through various social media platforms, through partnerships with social media influencers, and through peer-to-peer paper pass cards. So it was a mix of digital and non-digital. And then the second piece was an automated platform called EngageSpark, which operates somewhat like a simplified chatbot. So it responds to, it pushes out customized behavior change messaging, responds to young MSN via SMS, and then links young MSN who are ready to test to a peer educator. And then the third portion of the program was a streamlined delivery of HIV self-testing kits to young MSN who said that they were ready to test, and then having a streamlined process for reporting back of those self-test results in order to minimize barriers to testing and really maximize privacy and convenience for young MSN. So these were a couple of the examples just to give you a tangible sense of what young MSN were seeing. So the pass cards and the paper flyers are on the left there, the example of a digital ad on the right, and all of the visuals, branding, and messaging as part of the campaign was all co-designed and extensively tested with young MSN as part of that human-centered design process before pilot implementation. So you can see that the vibe and the brand is bold, it's positive, it's it's sort of proudly queer, and a little aspirational, dreamlike. So this is what a journey is for a young MSN who engages with Almasi. So starting at the left, he sees the campaign ads that I just showed you and then texts a short code in order to sign up to receive messages. And then immediately upon subscribing, he receives encouraging messages to test. And then when he texts that he's ready to test, he's linked to a peer counselor via SMS. And if he doesn't respond and say he's ready, he continues to receive encouraging messages that are tailored, behaviorally informed messages encouraging him to test. So within 24 hours of him texting that he's ready to test, the peer counselor schedules an HIV delivery, self-test delivery with him, along with lubes and condoms. So those incentives were very important as well as part of that package. And then he takes that delivered HIV self-test kit, self-test at home, reports back the results, and then receives a small airtime reward for doing so. And then he's linked to care or preventative programming based on his test result. So that is the overview of what the journey is, what the intervention is, and I'm going to pass it to Pascal to talk about the results in more depth.
Thank you very much, Theo. My name is Pascal. I work for HOYMAS Kenya, and I'm going to take you through the results. Like Theo said, I think I want to explain a little bit more of exactly how we got to the results that she put up in the front, and also exactly what the process she talked about actually delivered. Next, please. Like she said, like Theo said, we had around 800. We had an ad campaign, and in total we had around 800,000 persons actually viewing, engaging with the content that we are posting out there, out of which 1,754 subscribed to HIV testing through the Engage Spark platform, and also out of the 1,754, 1070 subscribed and actually said they were ready to get the HIV self-test kit. And out of this, we managed to deliver 980 self-test kits, which were from the 1070 who actually followed up after they were ready and actually continued engaging with the peer counselors. Out of the 980, we had 961 persons report back, which was around 99% of persons actually reporting back that they tested, these were the results, and they actually want more services, not only HIV treatment services, but also other SRHR services. We had 27 persons out of the 961 testing positive, out of which I think I remember over 90% actually already linked treatment in either of the sites. Next, please. So compared to other interventions that we've been holding, including physical outreaches, getting persons to come to the clinic, we actually, between 2019 and 2020, and especially the Q3 of 2020, and especially considering we were implementing this intervention during the COVID period, we had an over 264% increase in the persons who actually were reached in the intervention compared to our traditional outreach methods that do not include any kind of digital interventions. Yes, some of them do with the peer educators trying to reach persons online, but we actually had quite a big number of increase with the Almasi challenge, and also for the persons who are receiving the testing. There was over a 200% increase in that as well. Next, please. Like I said, and especially compared to 2019 pre-COVID, we still had a bigger reach of young MSM, and especially those between 15 and 20, because they actually had something they could relate with. We had over 120% increase in persons who never tested as per the guidelines, which is quarterly, which for us was a win, and also over 800% increase in persons who had never tested before, because they did not have the capability to go to the facilities. They could not reach the facilities, but when the facilities decided to deliver the self-test kits, at least they actually were able to get that. And also part of the program was most of the persons who were part of the program had never tested before. We had over 73% of the persons who were part of the program had never tested before. Most of them were infrequent testers, and also quite a number of them were persons who had never tested before. And like I said, I think somebody had talked about the fact that persons who are within that age group find it hard to go to facilities, and also the guidelines were, I think they are relatively new, and a lot of persons cannot still access the services that they need to. Next, please. For like we said, the program was was in 2 counties, and the dynamics of the counties actually showed us that no size fits all, because like we can see, a lot of persons in Kisumu responded very well to the physical flyers that were being passed around, and a lot of the persons in Nairobi preferred the influencers and influencer digital ads. So I think part of this, like somebody said, actually meaningfully engaging the young MSM in the programs the program we were running actually contributed a lot to this, because these were the persons who actually were deciding and designing these flyers, designing the influencer ads, and actually, like, we actually did see the difference. And one of the learnings from that was no size fits all for us. And yeah, next please. So the other part of our program was offering incentives, like Theo indicated, and also repeating what I just said, no size fits all. The young MSM who are designing the programs actually came up with the kind of incentives we were going to offer, and we had incentives, similar incentives for both sides. But we can see, from this, there are very different motivations for persons actually preferring. The preferences were very different. Like we can see for Nairobi, a lot of people preferred the flavored lube, while in Kisumu, in MAAYGO, a lot of persons preferred getting the airtime incentive. And also we can see, like, over the board, like for the scented condoms, a lot of both groups did agree, but there were specific individuals who wanted specific things. Like you can see, there's still quite a lot of differences between what each of the different populations wanted based on the dynamics of where they are. Next, please. We can see here we had a few quotes from some of the young MSM, and mostly one of the key things one of the key learnings we had was persons who want to actually be engaged. They actually prefer not having to meet a peer educator, not having to go to the clinic, but actually being just talking to somebody online and actually getting the service that they need, if that's possible. And also, a lot of the people were really appreciative of the kit being delivered to them, regardless of where they were, because and one of the key learnings was that the reason one of the reasons why young MSM are not testing is because of fear, and a lot of them are not only struggling with the fact that they are gay, but they're also struggling with the fact that they might be HIV positive, but they do not know where to go for testing. Thank you. I think I'll pass it on to Ken to talk us through more of the lessons we had during the Almasi challenge. Karibu, Ken.
Thank you very much, Pascal. My name is Kennedy Olango, and I work for Men Against AIDS, that is MAAYGO, as program in charge. And I'll be taking you through some of the lessons that we learned during implementation of this project. So we've come to realize that, especially in terms of outreaches, for us to ensure that we get the numbers that were requesting for services, we use the Engage Pack, which Pascal or Theo explained earlier was an automated SMS platform enabled and scaled for engagement with a number of much wider YMSM than the previous peer-to-peer approaches, and enable the immediate automated referrals to a peer counselor based on their location. So this was a form of, this process was very much confidential, and kind of, it helped to boost up the agency among the young MSM to request for these services. Then the targeted ads with MSM specific health messages across TikTok, Facebook, and Instagram drove the engagement and partnership with the LGBT social media influencers were also crucial, especially in reaching the young MSMs between especially the age of 15 and 19 years. So we had identified a few social media influencers who have a large following and who also identify as queer persons in the community. So just to help us share these ads and share this information so that young people who are following them, who identify as MSM, could see these messages and see how best to access these services. And then there was use of mixed both physical and digital channels, which help to bridge the gap in technology access among YMSM. As Pascal had explained earlier, we used social media platforms, but also we used peer-to-peer approach and even snowballing, and also some of the flyers that were distributed among YMSM. So in the snowballing process, we used identified young MSMs to reach other MSMs in their social network and give them the flyers so that they can access these messages. Next, and linkage to care. Remember the MSMs who were ready to test, through Engage Spark, got response immediately because they were linked to a peer counselor just to schedule an HIV delivery kit within 24 hours. And for us to ensure that this delivery is it's as fast as possible, we used boda riders, we used courier services, we used vans just to ensure that we deliver these test kits on time and at the right spot. Yeah? And then also we also realized that you could find that several young MSMs were expressing interest to get the test, maybe were coming from a certain locality. Let's say either Nyawita or let's say either in Ngara. So we could just tell them to be at a certain location. So we are able to deliver these commodities in bulk, because this helped in the ease to ease the time taking when delivering these kits door to door or place to place. So that also worked very much effectively. So we could reach a large number of young MSM in one particular place. And then also we also had an on-spot ATS. HTS in that there are people who are not very comfortable to use the HIV self-test kits. So we could avail an HTS provider so that they are able to conduct these tests. And also we could orient them on how to use the HIV self-test kits. And so they're able to conduct the test by themselves, and we see just how best to support them in that process. Another thing that that worked also very well was the issue of airtime, the incentives, because our fear was in that because young MSM fear isolation because of HIV status, or fear being ridiculed because of their HIV status, there was a need for them to have a support system. And one of the support system was to ensure that they report back their results. So we offered airtime from 100 shillings to 300 shillings so that they're able to call back and report their results, because for us this was very, very key. there was no need of providing the test kits, and yet we don't know what the results. So this was one way to ensure that the results are coming back, and to also to analyze like how many are comfortable giving out their results, how many are comfortable to access the services, and how many are still even struggling with other issues that we can avail counselors to support them mentally. And yeah. Next slide, please. So we also had a few challenges, and these challenges was coming as a result of strict policy and especially gray areas in engaging with young MSMs for the first time testers under the age of 18, because you remember our guidelines insist on parental consent, especially when somebody is the age of 18. So we are really struggling on how best to ensure that we don't overstep within the policy requirements. And then the supply chain shortages of commodities. Remember, if you can remember, especially for those who in Kenya, we've been having a lot of shortage around self-test kits and the lubricants and the condoms. So we could receive a lot of requests. There was a lot of demand, but the supply was very much limited, to the extent that we had to seek for support elsewhere to see how best to resource for the commodities. And then peer counselors were key for kit delivery, but why MSMs were not comfortable sharing their results with results with them. So we avail a clinical number. We avail a clinical number so that they're able to call directly where they're not very much comfortable to share their results with their peer counselor. And so this also increased confidentiality, and they were able to report their results back. But these were just some of the challenges that we faced during implementation of Almasi challenge. So next, summary and steps, I can say that like what we've come to feel that should happen around Almasi is that Almasi is a digitally enabled HIV self-testing model that lowers the HIV testing barriers, either perceived or actual, for YMSM compared to traditional clinical-based testing techniques. The success of Almasi project indicates that the value of human-centered design in engaging with key populations, especially young MSMs, in the development of impactful programming intended to reach and serve them. And then also we can say that Almasi partners are actively seeking new partnership to expand and scale up this model in Kenya and in other parts of the country, because this is the YMSMs are communities that still struggling with issues around their sexuality, about their visibility, and so coming out for these services is normally a challenge. So if Almasi can help us, the way the result has shown to reach out to this population, then this is something that there's a need for us to scale up and see whether we can bridge the gap that we are having right now in our programs, especially in enrolling young MSMs between the age of 15 and 24. So thank you so much. That is what we have as Almasi team.
Thank you so much, Ken, Pascal, and Theo. Unfortunately, we are running a bit late, so I don't think we will have too much of time for the panel discussion. But I just wanted to say that there are lots of questions coming up in the chat. So I would request Theo, Ken, Kennedy, and Pascal to make sure that you take some time to respond to it. Just very, very quickly, Theo, I heard you say many times about, or it is the presentation said many times, about human-centered design. What is it? I know all of us have several definitions of human-centered design, but what was a key principles that you utilized in this project?
Sure, thanks, Barry. Yeah, so for those who aren't familiar with it, human-centered design is a structured, creative problem-solving process that's increasingly being used to innovate on behavioral health interventions where conventionally programming has flatlined or is stymied, especially in the HIV and SRH space and with young people. So I think in practical terms, just briefly, what I'll highlight is two things that human-centered design does and that we did in this project. So the first key thing with human-centered design is really placing the intended beneficiary, in this case, young MSN, in the driver's seat of the intervention development process to ensure that their voices and ideas are at the center. So with Almasi, for example, young MSN were hired to be core members of the intervention design and evaluation team. And we had over 100 young MSN who were directly engaged to give their feedback through focus groups, through interviews on early intervention ideas. And the intervention approach changed based on their feedback, right? The intervention that you see today is very different than what we first thought it would be. And that was as a result of that feedback process. Yeah, and then the second thing I'll highlight is just that human-centered design involves conducting rapid cycles of testing ideas and materials with young MSN to understand where is this going to fail, why, and then improve it. And so through that, again, those ideas evolve quickly, and then and the idea evolves towards what young MSN, what's actually going to work with young MSN, rather than just what we might think based on paper or based on evidence, which is of course important to use, but also important to combine that with direct testing with young people.
Thank you, Theos. And a last question to Kennedy and Pascal. There are a lot of questions that are coming on the chat, and one of it is that you met a lot of new young MSM through this pilot project. How did you ensure that these young MSM are continue to link with your program? Did you register them? Did they get space in your cohort register? Did they come for clinical services? And then did they continue to stay in your program and get linked to ART or whatever? So how did you make sure that all these new people, even if it's 90% or 80% the new people that you contact, especially young people, continue to be part of your program?
You can go, Pascal. Oh, sorry, Ken. Like Kennedy mentioned, I think a lot of organizations are already trying to implement digital programming. And so for us, in a lot of cases, we had them join groups, and especially because WhatsApp has become very popular amongst a lot of persons. So we had them join WhatsApp support groups, and also utilizing other platforms like Facebook, Instagram, TikTok, to continue talking to these persons, because it's not only the influencers that we're using, we were also using case navigators in our implementation. So the case navigators are still following up on these people, and most of them, and especially the ones who reported that they were ready to test, have already come back to the programs, and they are continuously receiving services. But as per the other number, we are still trying to continue reaching out to them through Facebook and etc. And also the biggest part, I think this is answering part of the question that was in the chat. Somebody asked how we managed to get so many persons to come back, and we realized incentives, and especially for the 15 to 18-year-olds, were very important, because they are not able to get, let's suppose, condoms and lubricants anywhere else, and they are in a lot of cases they are afraid and they are ashamed to actually go pick these things. So that's how we actually managed to get a lot of people coming back, because they wanted more of what they were given with the self-test kits that we're delivering.
Just to add a few things is that we, as a Almasi implementation team, we emphasized on the safety and the security of the young MSM. So one thing we did is, first of all, was to sign code of ethics to ensure that we do not do any harm to young people, and to ensure that we create a very safe environment for them to access these services. So there was no need of harassing them either sexually or trying to intimidate them in one way or the other. So this kind of make them to feel safe with the whole intervention. Also, we took them, for those who are willing to come for the program, we took them through what we call informed consent. We asked them whether they'd allow us to take their phone numbers and even just do follow-up with them every quarterly, and even if they are willing to come to our spaces to continue accessing services. So for those who are very much willing, were taken through the informed consent, and once they have agreed, they were linked to peer educators, their phone numbers were taken. So it made it very, very easy for us to do follow-up for them to continue accessing these services. Yeah.
And maybe, sorry, maybe just like Ken had mentioned, as part of the Almasi challenge, we came up with an application that's on the on the Play Store. It's called Chukua Hatua. And like Ken mentioned, we are looking for partners to actually make sure, like currently it's not active because there hasn't been funds to pay for it. And we are always looking for partners to actually continue this. It's called the Chukua Hatua. I'm sure very soon it will be on the Play Store. So everyone here, maybe I'll type up the name on the chat and you guys can look at it, but it was informed by this challenge and it should be a good application for all of us and especially for the community-based organizations working with young people. Thank you.
That's great, Pascal. There is interest, so please write it down. And for the Almasi Challenge team, I think Mary Mugambi has clarified on the age for the lower age for HIV testing. You may want to have a separate discussion with her. I think one thing that I found it very interesting from the Kenya presentation, all the 4 Kenya presentations, is that it is easier possibly to implement or carve out a special space for young key populations within a larger adult key population program. So all the institutions or organizations who started program for young key populations actually had a running program for already adult sex workers or MSM, and they carved out a special place and piloted and tried new things for young key populations. And some of the principles that they all kept in mind was do no harm, consult, take consent from the young key population, design an intervention that kind of suits and meets their need. And you'll see the same thing happening in Zimbabwe. So I'll just move on quickly to Primrose, who's going to be presenting on the Zimbabwe experience. And we are running 5 minutes late. So I will also request for indulgence for 5 minutes beyond the time of this Link and Learn session. So Primrose, over to you.
Thank you, Parinita. I'm going to talk us through how our programming for young female sex workers in Zimbabwe has evolved since we started the program for sex workers in 2009 up to 2022. CeSHHAR is implementing a nationally scaled program on behalf of the Ministry of Health and the National AIDS Council with support from PEPFAR USAID and Global Fund, and then some specific support for young key populations as well with UNFPA and Antwerp. Next slide, please. So what we've focused on is really always making sure that whatever adaptations and scale up there is in the program has been based on the evidence from the global context, but also specifically from our local context in Zimbabwe. And since 2009, when we reached out in its first year to 322 female sex workers, 25.8% of whom were under the age of 25, we've relied on evidence coming from specific studies, some respondent-driven sampling surveys, and other smaller studies, quantitative and qualitative, with young women who sell sex to understand their needs better and to adapt the programming we were doing so that we would have specific programming that met the needs of these young women. So that is how we have adapted, as you can see in this diagram, and these slides will be shared, so I won't go into detail, up until the point where we are now, where we're up to about 32% of the sex workers we're seeing being young women attending services. And we now see per year in excess of 33,000 sex workers. Next slide, please. So it's just showing you here the scale up of the program. It did start with a small demonstration project in 4 sites, and we've scaled up nationally across the country. So we do have very good coverage and are able to use this coverage to reach female sex workers, and with the adaptations that I'll talk you through, young women specifically. Next slide, please. I'm going to talk you through our implementation framework for the program. And one thing that has always been important and continues to be is that everything we do is led by key populations themselves, from leading mobilization and empowerment to leading the linkage to comprehensive packages of services, and for HIV and sexual and reproductive health, but also for structural interventions. And you'll see in this framework that we're offering services from HIV testing, PrEP, ART, condoms, lubes, the DREAMS programming specifically for young women in those sites, but adaptations for young key populations across all the districts in the country. And then also having structural interventions around economic strengthening and targeting sexual and gender-based violence, and also providing mental health services. And these services are provided at facilities. We're co-located in government facilities throughout the country, but with set aside units where we provide services. And then these are also provided in the community. We go out to where the young women are, where key populations are, and provide at agreed points that they are comfortable in receiving services. And we also provide services at drop-in centers. And the chief purpose of the drop-in centers is to be safe spaces where people can relax and really just be able to be somewhere where they're feeling safe. They can have entertainment, recreation, but they can also access services. And of the 10 drop-in centers that we have in the program, 6 of these are specifically dedicated to young women who sell sex. They're known as the girls' clubs, and these have been adapted specifically to what the young girls have said they would like to see in their safe spaces. Next slide, please. So I'm just going to take you through in a couple of slides some of the data that has informed how we've adapted the work we do with young women selling sex. And some of these papers, I think Perry will, or the SSLN team will be able to share the links as well in the chat box, and you'll be able to look at them more closely. This one is really talking about what we were able to understand about incidents in young women who sell sex, the higher incidence in these young women when they were compared to older female sex workers in the program. And the incidence was 6.3 per 100 person years in this age group. And it was also higher in the first 5 years. Those with lower duration selling sex had higher incidence. And so it was important to really, with prevention interventions, tailor them to the needs of young women who were most vulnerable and most at risk to HIV infection. And when they were new to sex work and did not have the same understanding of how to negotiate condom use and consistency of condom use and linkage to prevention methodologies, they had higher risk as opposed to later on with older sex workers or those who have been selling sex longer. Next slide, please. And so after the first couple of years of some DREAMS implementation within the country and focusing on young women selling sex, we undertook an impact evaluation in 2017. And that has been able to inform further adaptations in the past few years to improve the way we were working with young women and how the services were being tailored to their needs. Following that impact evaluation, there had been high coverage of services, and HIV testing was improving. But in terms of the outcomes, while there were positive outcomes such as fewer clients, which is associated with lower risk of HIV infection, there was increasing use of PrEP, and this was in the early days of PrEP in the country. There was ability to negotiate condom use was improving, and there was a reduction in condomless sex, both with regular partners and also with clients. There wasn't statistically significant impact, but there was reduced HIV incidence, 26% after 2 years. Next slide, please. Sorry, I have a bit of a lag on my end. I think we've gone backwards. Thank you. So some of the key lessons that we took away from that process of the impact evaluation were that while there was access to condoms, young women who didn't identify as female sex workers had less access. And so we needed to be able to reach them and meet their needs without them having to access services that made them have to identify themselves as sex workers. And although there was a high knowledge about the efficacy of condoms, the consistency was low in younger women compared to the older female sex workers. So there was a need to more individually support the condom use and understand any difficulties that were being experienced. There was also a need to start addressing better the structural determinants of the risk of young women selling sex, because we saw that those who had experienced sexual violence were less likely to use condoms. And this was statistically significant. Those who experienced common mental disorders in the past week were less likely to use condoms. So failure to address these issues was going to continue to leave these young women vulnerable. Next slide, please. So having introduced and scaled up micro-planning, we focused on adapting this peer outreach, this enhanced peer outreach for young women, that not previously we hadn't paid as much attention to ensuring that there were micro-planners in the age group of young women who we were trying to reach. So we identified and trained 16 to 24-year micro-planners to offer this risk differentiated support, where they individually get to know people, and in their cohort, they assess the risk of each young woman that they are supporting. And they have cohorts of up to 70 young women that they support each micro-planner. And they assess their risk and get to better understand the individual needs of each woman that they are supporting, and are able to support them with improved condom use, link them to services that, such as pre-exposure prophylaxis, and with the LIVES approach that we use for addressing gender-based violence, ensure that they get support if they have been, through routine inquiry, we pick up that they are needing that support. We also, in terms of the community cadres that would be working with young women, made sure that young women weren't just with the micro-planners, but they would also be part of the lay mental health counselors who work through a lay mental health counselor approach called the Friendship Bench. And so they're young women who are Friendship Bench buddies. We also have economic strengthening in the DREAMS programming. And so the community-based facilitators are also these young women. And then in these girls' clubs, which I've mentioned earlier, which are the drop-in centers focused on young women, we have a manual that was adapted specifically to their needs and how they wanted to learn about different sexual and reproductive health issues. We also moved to having a one-stop shop. We did have a need to refer often for certain services, and this we would often lose young women along the cascade. And so having this one-stop shop was the further adaptation made. Then there's support as well through young women who are supporting an adherence. It's called the Young Sisters Adherence Program, and they pair up with, it's status neutral, and so they support either on art or PrEP just being able to adhere to medication. In this image here that you see, it's one of the young women's drama groups in Bulawayo. They are in the girls' clubs, different activities they come together to do. One of the popular ones in a couple of the districts is they have these entertainment drama groups, and they also come together to play different kinds of sports in those facilities as well. Next slide, please. So this is just talking through the risk-differentiated peer support that the microplanners give, that they first have mapped the areas in which they find these young women. And it's not just bar-based or street-based. These young women sell sex in different places. Sometimes it's in group homes where they live. Sometimes it's on online platforms. But we certainly know that the young women know best where to find young women and on which platforms and in which areas and how to reach them. And they managed to map those areas, it also giving us an ongoing update for population size estimate. And then they encourage them to take up services. As I've mentioned, they have a risk assessment they do based on 6 criteria, which helps them just better focus what kind of support in which areas this individual needs. And then they follow them up continuously, either weekly if they're at highest risk or minimum on a monthly basis. Next slide, please. This is just showing you sort of an excerpt from the girls' club manual. These young peers deliver sessions to the young women, and it's guided by a manual that has been adapted to their interests and needs. And this is the example of that manual. It's also available on our website. Next slide, please. The other thing that the microplanners do is support self-help groups among the young women. And we found that the self-help groups have really supported improved resilience and empowerment through social cohesion, where when they come together, they have a collective that supports each other, there's solidarity, and they have often expressed feeling stronger together. They have the mental health interventions through the friendship bench buddies, but even the coming together and talking through issues and comforting each other on issues has improved the psychological resilience. They have financial literacy training and internal savings and lendings groups that they set up and receive starter packs for entrepreneurship ventures that they're starting up. And they also have come to really feel more empowered to demand better services. So the microplanners do support them to speak up for themselves where things are not right, to feed into the feedback mechanisms that they are within the program and strengthen their services. Next slide, please. The other thing that was important was that as the program matures, we ensure that it's, although we have had long-standing ways of how do sex workers take ownership of leading their services and also take ownership of the program, that young women did not get left behind. So we have made sure that young sex workers can inform and lead implementation and are central to providing the services by having it clear how they would be eligible for positions in the program that they would be interested in. So there is a clearly defined organogram for the program. What are the job positions in them? What would someone need to be able to do those specific jobs? It's been important that we don't have the program only have young people only doing the community cadre work and not able to do any other roles within the program. The other thing that we saw was you needed to identify each person's training needs and support those training needs, and then prioritize these young women when these opportunities become available. Next slide, please. So this is just going into a little more detail about this career path for young women in the program. We have in this first column, what I've talked about a lot, the community cadre positions, which is their entry point. They are the microplanners providing this differentiated support for engagement and services. We have, for the economic strengthening, these community-based facilitators who are training and supporting the internal savings groups and also those trying to start their businesses, the mental health support, PrEP champions, Dreams ambassadors. And what happens with the outreach workers then support each of these community cadres with its capacity development plan, so that they get a better understanding of the young community cadre. What is it that they want to do in the program or elsewhere, and what support do they need for those opportunities? Then within the program, we do offer a 3-month internship program on a rotational basis, and we take about 80 interns per year across the country. And they're able to then shadow in different areas within the program that they're interested in, whether it's in the social work aspects or data collection and analysis, they shadow in those areas. There's also, through CeSHHAR and several implementing partners, other opportunities for vocational training or tertiary education or second chance secondary education. And we also ensure that they can get those opportunities. And as I've said, when the program has posts, then we prioritize those applicants. And we have seen this happen, that they increasingly qualify for these posts and take up those posts. Next slide, please. So where are we now moving forward? We have seen that young women transition in and out of sex work more than their older counterparts, and that we don't really have a full understanding of how that affects their engagement in services and how we should ensure that we support them to engage in services whenever they're at risk and not lose them along the way. Better understanding their partners. The programming has often not focused on male sexual partners enough. And then when they don't get services, we are looking things from one lens, and we do not adequately reduce HIV risk of acquisition and transmission. And so we're also looking at better characterizing in which locations there are the populations that are at greatest risk. There's some work underway now with a diary study to look at transitions in and out of sex work, tracing those who we've lost. What is it that we could do to better keep in touch with women who are engaged in the program and not lose young women in services? And also currently there's some place studies going on to have a better look at the partnerships, male partnerships, and what HIV is looking in specific locations. So that's where we are now. And I think I'd like to just say, as I round off, that this is part of our understanding that you have to evolve and be intentional about how we involve services that reach young people, young women selling sex. It's constantly evolving, and they are best to lead in understanding how their needs change and how to better adapt services to meet those needs. Thank you.
Thank you, Primrose, for the presentation. Every time you speak, it's as if I'm hearing you speak for the first time. We're actually excited. I'm particularly excited to see the slides where you're sharing the career pathing for sex workers, such that they are not only recipients of service, but providers of care, and within that provision of care, ensuring that they have a career path to follow on their dreams, as we all do within the work that we are doing, providing healthcare services for our communities. Let me open this session for question and answer and any discussion that colleagues may have. So you can show by raising your hand and continuously to use the chat box where you feel shy to raise your hand. Any questions for Primrose? Yes, Pari, I see your hand. Please proceed.
Thank you. Thanks so much. I agree, Humphrey. I've heard this presentation a few times, but Primrose adds new elements to this presentation, so it's always new for me. Primrose, what I understand from your presentation and when I saw some of your slides, that you've had multiple funders fund several parts of this program. So it may have been a little bit easier to do such a comprehensive program for young sex workers. But if a program in a country does not have multiple funders, and if they want to do within their sex worker program or an MSM program, if they want to do a special element for the young sex workers, what would be the key things that they could start with? I mean, what were some of the most impactful interventions that you found in your work that you would say, these are the two things that you should start with, and then as resources come in, you can expand it, you know?
Thanks, Perry. So definitely at the moment, the program is really well funded, but it wasn't always this way. And I think what we are constantly aware of is that everything has been possible to adapt to young women and to other key populations because of the stewardship and the leadership of Ministry of Health and NAC. And I think that is really important, that it's difficult to set up strong programming with that, because without that leadership from your Ministry of Health and your National AIDS Council, because you're going to need that policy development environment and in terms of the health facilities to support any adaptations. There can be difficulties with serving younger key populations below the age of 18, and you need to have your support of your ministry and NAC to be able to navigate those law and policy difficulties. So I think the first thing is to have that relationship strong if you're an implementing partner with your ministry and your National AIDS Council. The other thing which is important is if you already have programming for sex workers and you want to adapt it better for young sex workers, is to better understand their needs and how you would be able to adapt what you are already doing. So if they are having difficulty accessing a facility, and I think it was mentioned in an earlier presentation, on a specific day and say, we could come to this place, but only on a Saturday, that's an easy change to make, and you provide a service on a Saturday. Or if they say, but if you came to us, if you just gave a mobile service in this space in the community, we would feel more comfortable because we can't be seen walking into that service. So understanding the context and listening to what the needs of those young sex workers you are serving are, can easily adapt a service you are already giving. Thanks, Barry.
Owen or Pascal? Pascal, if you can come through, yes, over to you.
Okay, maybe just following up on Paris' question, and especially around the fact that the project had many funders and many partners. So while implementing the Almasi challenge, we only had one partner, and it's been quite a bit of a challenge actually getting other partners to come on board on a project that another partner has already funded. Maybe just, I think my question would be exactly what was the resource mobilization strategy that enabled you to get multiple funders into the same project? Thank you.
Thank you. So we've been fortunate to have the funding from PEPFAR, which has a specific interest in DREAMS. And so there are DREAMS funded districts. And what we've done is then leverage on that funding. For instance, with our global fund support, we already had designed the package for young sisters. So it didn't need to be limited only within DREAMS districts. Young sisters could be implemented with support of Global Fund in the other districts that PEPFAR did not support. And so we had the documentation. I think documentation is important. If you can write up what your learnings are on programming with young sex workers, So you have the evidence when you are approaching funders to say, we've seen what works and what doesn't, and we need to scale this up. And we were able to include that in our approach to Global Fund in our current funding stream. Also to be alive to opportunities that may not have large scale funding. Some of our funding has not been to the scale that PEPFAR and Global Fund offers, but for instance, the Antwerp had a grant just for young women to get vocational training and second chance education. And they only wanted to support where there was low funding. So that was an opportunity to support women who were not in a Dreams district or in somewhere else where there was good funding support. Even though it wasn't a big pot of money, it's very important. It has transformed, you know, a couple of hundred women's lives, and it's been really important. So to have access to keep engaging, UNFPA also does not fund the program on a large scale, but does give specifically for young women in certain areas. So whenever an opportunity became available, we don't only focus on where there's lots of funding available, but every amount counts, and you know, every person who you can reach with it matters. So we've been also taking advantage of where we get access to smaller amounts of funding. And yeah, document. Thank you.
Thank you, Primrose, and thanks, colleagues, for the questions that you have posed. I think Primrose has made efforts to answer very succinctly. There is one comment from GK on the chat. They say, Primrose, thank you for this presentation. This has helped me to reframe my thinking around how we can start reintegrating dreams amongst young women. Oh, sorry, I've just lost this. I'm sorry, amongst young women who sell sex, which we are already implementing. It's such a learning curve for us, and this has really helped. So thanks a lot, Primrose, for your clarity and for the eye-opening revelation for other colleagues. Lastly, we want to shift gears to have a bit of reflections from Ghana, from Mozambique, and from Malawi. Just we want to understand what did you learn and how would you plan to use these lessons in your country? What did you learn and how would you use these lessons in your country? So without any specific order, Ghana, Malawi, Mozambique, if colleagues can share their reflections on the session. Perhaps we start with Ghana.
Oh, okay.
Or if you're ready, please go through. Hello. Hello.
Antonio, you are muted. So in case you are speaking, then we cannot hear you. You had started speaking, but then you got muted.
All right. Thank you, Andrew from Mozambique. So first of all, thank you for this reflection, these examples that were shared with us. And it's really very important for us as Mozambique. As you may know, we are now starting with the TSU discussion around young key population. It's a really new discussion in Mozambique, and we had the opportunity to learn from Kenya. Recently, we had a visit for almost 5 days, where we could visit different interventions among key populations, especially for trans sex workers and young MSM. and we could take some very, very important takeaways from this. One of the takeaways that we had and we could see, and we will see within the country how we can capitalize this. It's the presentation that was done from Almasi, which is especially referred to the HOYMAS. I think the issue related on the automated SMS platform, it's really very innovative, and I think we will just go through the local organizations that are working with the key population and that are funded, because to establish this platform, surely we'll need some support, some funding for it. But I feel that it's a very innovative strategy, and we can take it as a takeaway for us. We could also note that for Kenya, interventions with the key population have started for a while ago, and they have a good experience in which we would learn from it. And as a country, we don't yet have a guideline which it's addressed for young key population. So this will be also one of the key takeaways that we have to establish in the country, with has support surely from SSLN to have these guidelines so that we can really address for the young population in Mozambique. And as well, we could see the strategy on the key population, the presentation from Zim. Feel that in the country, we also have started some strategies to strengthen sex workers. And we have a limitation as a country in terms of the ages to deliver services, especially for key populations. So this is a discussion that we are having with youth secretary, because we have to address this service for young key population. And some of them, they assume that if we deal on sex work for young women, it could be seen as children services. So how can we discuss with them to show them the needs for this young key population? So in general, I think that from this webinar, from these two experiences, we can see that we are still have challenges, especially in terms of this micro planning for young key population. And we, as a country, we will really need to start this discussion and reinforce it into the and do the advocacy within the government in order to have specific guidelines that can address especially the service for this young key population. So this is my remarks from this call. Thank you.
Thank you, Antonio, for your reflections and the journey that Mozambique is on. Maybe to reiterate that colleagues on the call and are ready to share experiences from Zimbabwe as we have, and to take these conversations continually beyond this platform to ensure that you really are primed up to change the face of implementation for young persons in Mozambique. Can I invite colleagues from Malawi to quickly share? I'm noticing that we already are beyond the hour of 4 and we want to wrap up very quickly. Malawi and then Ghana.
Thank you so much. I'm Grace Mwenda. I'm a champion and I work with a local organization called Bhattacharjee. Thank you so much for this webinar. It's been super helpful to just learn from Kenya, learn from Zimbabwe on the work that they're doing on working with young key populations. I think as a country, we do have quite a robust key population program. We have standard service packages that are quite determined by the government, but also National AIDS Commission. However, I think from this webinar, it's quite clear that we haven't started working around tailoring services or packages towards young key populations. And we have clearly learned that policy guidance is very critical in this process, especially learning from the case of Kenya. So what are we taking away? One of the things that we'll probably do from this call is to go back to the key population technical working group and put this on the agenda, to say that we do have young key populations, and this is something that we haven't had a conversation on as a country, and perhaps present some of the data that we have at program level, and also some of the case examples that we've heard today. So this, we hope, could potentially start the conversation around young key populations, and we will probably start thinking around strategies as well and policy guidance. So the starting point is we'll take it to TWG, Technical Working Group, for discussion. The second thing that we're looking at as an opportunity is we potentially have a population size estimate exercise that is coming up in 2023. And this gives us an opportunity to look for data that speaks specifically to young key population, because at the end of the day, that's where everything starts. We need to understand the dynamics. We need to know what kind of population dynamics we're looking at, and that will inform programming. So that again can be pushed into that conversation that is already happening right now as we start thinking of population size estimates at national level. We've also learned that we do need to develop strategies that are youth friendly. This has been, I think I commented in the chat box, it's been a huge learning curve. We're doing quite a lot on key population already as a standard program, but we are learning that we can employ digital platforms to reach even more to the young key populations. So this has been a learning that, as we share with the technical working group, we'll also take that on the table and bring it up. And finally, I think the last one that I think offers quite a huge opportunity is from the countries that from the districts that PEPFAR is funding. We do have some districts that are overlapping DREAMS and key population. So the DREAMS program is working with young women who are same sex. And I think it gives us quite a huge opportunity to start looking at a very structured way of working with this population and of seeing how that could be expanded into quite a bigger program and scaled up as we move ahead. So already there's an opportunity for integration, and we'll start looking into that as well. But as a starting point, I think as champions, I will report back to the team that is not here, and we'll see what are the next steps that we could take from there. Thank you, over.
Thank you, Grace, for those reflections on behalf of the Malawi team. You remind me of the fast track implementation, or the fast track plan that Kenya was talking about. It sounds like you're going to be thinking through a roadmap of what you're going to be doing to particularly focus your interventions towards responding to the HIV epidemic amongst young persons. In Malawi, you're thinking of a TWG, you're thinking of ensuring that you analyze your disaggregated data from your opportunity of a PSE exercise, and also exploring how you're going to use some of the information we've had here around utilizing or leveraging digital tools for the work that we do, and integrating KP and DREAMS programs in overlapping districts. I think that those are very amazing takeaways. Last but not least, can I invite colleagues from Ghana to share their reflections and takeaway? We can have colleagues from Ghana come through. Do we have a representative from Ghana?
I am from Ghana.
Hello.
Hello.
Okay.
I'm
Hello.
from Ghana, but I thought JSI who shared this will be, but I don't know if I have
hello.
other Ghanaians.
No,
Yes.
Cecilia, you can go ahead. At least all we have to share is our perspective as implementers. So you share your perspective as a leading implementer of community-based programs and then also a member of our coordinating mechanism. So you go ahead. If there's anything else, I can also add. But it's been a wonderful presentation. And I believe that for us who are also rolling out young KP programs now and trying to integrate it, we've had some significant learning that we can apply to our situation here. So thank you very much. So Cecilia, please go ahead and say something.
I think it's been very wonderful listening to the presentations, the innovations, the strategies. I've been hearing dreams. Recently at the International AIDS Conference, I visited their booth and I realized that these are all very wonderful strategies, innovations that they are using. We have been working a lot through JSI and FHI, but for us, one of the key things that I've seen is the community level, community engagement and the strategies that you use to ensure that their services, their needs are well addressed. It is important that as a country, we also integrate this. And I know we are doing a lot, but we have learned a lot. And we thank you for that opportunity. I know Global Fund is also focusing on that. I'm talking at that level under CCM to ensure that resources to support this group is very key, because from the recent presentation by WHO UNAIDS, we realized that young people, key and vulnerable population are being left behind, children are being left behind, and these strategies will help us also to move forward as a country. And we are very grateful, especially to GSI EDBEC for sharing this link for us. I participated throughout and I'm so happy. Thank you, very wonderful presentations. Thank you.
Yeah, so thank you very much, the team, the SSLN team, for this package of interventions that you've shared with us this afternoon. It's been a great learning experience. I think it's reinforced our belief that yes, young people are getting marginalized. And we know the continent we live on, there are cultural, socio-cultural issues that prevent them from accessing services. And so any which way we can organize services, provide it to them, integrated it as part of the reproductive health support programs, and also to enable them to feel free with providers is all helpful. So thank you very much. It's been a wonderful education. Thank you.
Thank you, colleagues. We had a promise to have the last 10 minutes of this session to round up. It's 10 minutes after 4. I'd like to take this opportunity to thank you all for the hard work that you do. It has been really a successful linking and learning session to all the presenters and the coordinators and everyone who facilitated this linking and learning session on young key populations. It is truly appreciated. Kindly take a second or two to respond to the poll that is currently showing on your screens before you log off. And until we meet next time, have a good afternoon. Goodbye.